Hybrid coronary revascularization continues to evolve as a sophisticated, best of both worlds strategy for multi-vessel coronary artery disease. By combining the gold standard durability of a left internal mammary artery to LAD bypass with the lower morbidity of percutaneous coronary intervention for non-LAD lesions, LAD is left anterior descending coronary artery. Hybrid coronary revascularization addresses the primary limitations of both standalone CABG and multivessel PCI. Hybrid coronary revascularization typically involved Lima to LAD bypass with minimally invasive direct coronary artery bypass, that is mid-cap, complemented by PCI to non-LAD vessels. Recent comparative data suggests that hybrid coronary revascularization is a viable alternative to traditional CABG, particularly for patients who are high risk for sternotomy but require the survival benefit of Lima to LAD graft. Short-term benefits. Hybrid coronary revascularization consistently demonstrates lower rates of blood transfusion, shorter ICU and hospital stays, and faster return to work compared to conventional CABG. Long-term survival. Mid and long-term survival up to 10 to 11 years appears comparable between hybrid coronary revascularization and traditional CABG in appropriately selected cohorts. The revascularization gap. While survival is similar, some studies indicate a higher rate of repeat revascularization in hybrid coronary revascularization compared to traditional CABG, often driven by the PCI component or the inherent complexity of minimally invasive surgical sites. The sequence of hybrid coronary revascularization remains a point of clinical debate, though institutional preference often dictates the workflow. Strategy. Simultaneous, performed in a single session in a hybrid operating room suite. Pros and cons. Immediate Lima to LAD assessment, but increased bleeding risk due to dual antiplatelet therapy and heparin. Surgical first strategy. Lima to LAD via mid-cap or robotic surgery followed by PCI days or weeks later. Pros and cons. Safer DAPT initiation, temporary incomplete revascularization because the two are delayed. PCI first, PCI of a non-LAD culprit, example in acute coronary syndrome, followed by surgical LAD bypass. There is immediate treatment of the culprit. Disadvantage, risk of stent thrombosis during surgery. Recent 11-year data suggests that short and long-term outcomes remain excellent regardless of whether the surgical or PCI component is performed first. Despite its theoretical advantages, adoption of hybrid coronary revascularization remains low, representing roughly 0.5 to 1% of all revascularization procedures in large databases. Primary barriers include infrastructure requirements, the need for specialized hybrid operating suites. Expertise, high technical demand for robotic or thoracoscopic Lima harvesting. Heart team collaboration. Success requires deep integration between interventionalists and surgeons, which can be logistically challenging. Long-term survival rates for hybrid coronary revascularization are consistently reported as non-inferior to traditional CABG across various cohorts, extending up to 10 to 11 years of follow-up. Survival rates. Studies with a median follow-up of 11 years report survival rates of 92% at 3 years and 85% at 5 years. Major adverse cardiac and cerebrovascular events. Total major adverse cerebral and cardiovascular events at 11 years for hybrid coronary revascularization is approximately 36.7%, with cardiac-related deaths accounting for only 5.5% of the total. Ischemia relief. Some data suggest hybrid coronary revascularization may provide superior long-term symptom relief compared to multivessel PCI, with 2-year results showing lower rates of angina, 5.5% versus 17.2%, and overall major adverse cardiac and cerebrovascular events in high-risk patients. The primary difference in long-term outcomes between hybrid coronary revascularization and CABG lies in the rate of repeat revascularization, which is typically higher in hybrid cohorts. Revascularization rates. Repeat revascularization in hybrid cohorts ranges from 2 to 7% in midterm follow-up. It is probably mostly contributed by PCI vessels. Graft versus stent performance. While the Lima to LAD graft in hybrid revascularization maintains excellent long-term result, that is patency approaching 100% in many series, the non-LAD lesions treated with drug-eluting stents remain subject to the typical limitations of PCI, such as in-stent restenosis. Current consensus emphasizes that hybrid coronary revascularization is most appropriate for patients with high-risk features where the invasiveness to benefit ratio of a full sternotomy is unfavorable. While hybrid revascularization is considered feasible and safe, the medical community continues to call for larger randomized controlled trials to provide definitive long-term recommendations and better identify patients who will benefit most from this combined approach.